This is our annual healthcare conference that's been sponsored by the Louisiana Department of Insurance since 1992. My predecessor's predecessor, then Commissioner Jim Brown, held the first one of these at the Broadwater Beach in Biloxi, Mississippi, and we've done it every year except 2008 when Hurricane Gustav washed us out. But it's well attended. 500 attendees here today. We bring together all of the experts that we can access, and we get tremendous cooperation from the State Department of Health and Hospitals, from the insurers, Blue Cross, Vantage, United, Humana, all of the above, and the agent community. We bring together the experts that discuss all aspects of healthcare, the cost, the availability, and we think it's of great value. I certainly learn a lot every year. And my feedback from our agents in attendance from all over the state is very positive.
What are some of the biggest issues facing healthcare and health insurance in Louisiana?
Well, as you might expect, it's the cost and the fact that the annual increase in the cost of healthcare outstrips the CPI, the Consumer Price Index, year in and year out. That's as a result of the fact that meds are getting better, cost of hospitalization is getting greater. We have the ability to treat with sophisticated instruments and medications diseases that we couldn't treat before. AIDS, for example, comes to mind, which was a death sentence 10 years ago, is now treatable and life expectancy the same as any other American. That's just one example of how healthcare has changed in recent times, the last 10, 20 years. Drugs are much more effective and more costly than they were a quarter century ago. We still face significant challenges, for example, with mental illness and the treatment thereof. We face challenges with the availability of primary care physicians. We face challenges with the availability of all health care in rural aspects of not just our state, but every state in America. I need not mention the challenges of the rollout of the Affordable Care Act over the past 5 years. We discuss all these things in an all-day session that attracts year in and year out 500, mostly agents from all over the state who take advantage of this learning opportunity.
Talking about increased cost of healthcare and the escalation, we know that healthcare costs are rising at about 7% each year, and it's pretty discerning that, you know, the budget plans would to get us to a less than 3% growth. So where do you take that from, or where do you make those changes in healthcare? We know that 40 to 50% of that growth comes from new technology or the reuse of old technology for new efforts and initiatives. But there's a certain portion of healthcare costs that we don't like to talk about. And that's the part that I wanted to open up with today. And that has to do with the 4% of where do we really focus our energy and effort when it comes to end-of-life care. How many of us have had the discussion? How many of us have an advance directive? The whole issue, April 16th this year is, each year, it's National Healthcare Decision Day, and it really is about starting a conversation, a dialogue about the decisions that one has to make. And if, in fact, you've not had the conversation, I encourage you to begin to have the conversation with your family, with your friends, about what it looks like for you to be treated with respect and dignity when chronic diseases and or decisions need to be made about care in the waning years of our life. That is where we can have lots of conversation about how do we drive down healthcare costs. But until those conversations start, until we take the leap of faith to share what that means, we're really not going to really bend the cost curve in healthcare. We can talk about technology, we can talk about lowering drug costs, we can talk about restrictive technology, expanding Medicaid, and we have lots of information we can share about that. Really excited that we're moving in that direction. But the one thing that we really don't want to talk about is the belief that Americans have that death is an option. I mean, truly, 4% of the population believe that with the next drug or the next procedure, I can extend the inevitability. And that's information that's published out there that you can pick up and read. So when do we change that perception? When do we change that perspective and truly have the hard conversations in our families? And so that's what I want to share with you all today, is that what's a takeaway from here? It's a personal commitment that you yourself have the conversation and have your, Cindy Munn's here with the Louisiana Healthcare Quality Forum, La Poste, and all of the efforts that the Quality Forum has done to roll that information out across the state are phenomenal. I encourage you to go to that website, look and see, and begin to have those conversations. That's when we'll take our own personal choices and decision and participate in bending the cost curve, not just here in Louisiana, but across the nation.
Thank you. Mr. Ford?
Yes, thank you, Donna. I'm going to focus somewhat narrowly on pharmaceuticals, and that's by design. I graduated from pharmacy school at ULM in 1989, and in the 27 years that I've been in healthcare, I've seen a tremendous amount of change. In fact, when I had just graduated from pharmacy school, Zantac was the #1 drug. We're probably all familiar with that, right? It's over the counter. And I remember the drug cost about $60 a month, and the thought was, oh my God, it costs more than a physician office visit. That was kind of a big deal. But the world's a little different now. Our #1 drug is Humira. It's a specialty drug. It costs about $4,000 a month. And in fact, there is a new trend right now that there are more specialty drugs being approved by the FDA than non-specialty drugs. That started in 2010, and that will continue. In 1989, there was no specialty drugs. There was no such thing, and that's kind of the juxtaposition there. The other thing was the generic drug industry was in its infancy. In 1984, the Hatch-Waxman Act created a pathway for generic drugs. So when I graduated, about 90% of the prescriptions that we dispensed were brand name medications. That's flipped on its head. And now this year for Blue Cross, about 85% of the prescriptions that we dispense are generic drugs. And something else that I think is a little different now than when I graduated is prescription drugs are consuming more of healthcare dollars. Just 10 years ago, shortly after starting at Blue Cross, prescription drugs made up about 18% of the pharmacy benefit of medical cost, of overall medical cost for a commercial patient. Now they make up 24%. Now, if you add in drugs that are infused in clinics by oncologists or rheumatologists, immunologists, gastroenterologists, all the ologists, right? You add that in and you're up to about 30% of the claim cost is prescription drugs. But a few things have not changed since I've graduated. Probably the first thing is healthcare is not a free market, okay? To be a free market, the consumer has to have the ability to choose. And part of the choice can be either saying no, delaying, or maybe choosing something else. But quite frankly, most consumers don't have the knowledge to choose what they need for their health care. And gosh, who would, right? You get a terrible diagnosis, something like cancer or some rare disease, you're relying on your physician to help you down that path and figure out what therapy's best for you. So the person that's paying for the prescription, the insurer, the employer group, the taxpayer-funded government program, is not the same person that's recommending the product, which is the physician, and it's not the same person that's consuming the product, which is the member. So, there's a little bit of a disconnect there. I think the other thing that hadn't changed is we have improving health at our core, everybody at this table. The mission of Blue Cross and Blue Shield is to improve the lives and health of Louisianians. That's at our core. We have many programs where we identify members who have chronic conditions, who aren't taking their medications, and we try just about every trick in the book to get them to take their medications, because we understand how important medications are for someone with a chronic disease. And that really is my third thing that hadn't changed. For many chronic conditions, prescription drugs are the cornerstone of treatment. That was true in 1989, that's true today, and that's going to be true in the future.
Thank you. Mr. Martinez.
Sure. Thanks for having me today. I represent the branded manufacturers at Pharma, and we are the research-based manufacturers. The pharmaceutical market, as Milam talked about with generics, and there's other folks that have gotten into the business, and I think we'll probably get into some of that on the panel later. But the folks that I represent have been the industry that has taken life expectancy in this country from 47 years to 78 years. That's a good thing. Death rates for HIV/AIDS are down 85%. That's a great thing. I remember being in high school and being, we're going back to the day, you know, when someone got that diagnosis, it was a death sentence. Now someone with HIV/AIDS has similar life expectancy of anybody else in this room because they're able to be treated with medications. And we talked about specialty drugs a little bit, but the new technologies that are coming out now are that we've seen in the last couple of years. I'm sure we'll talk about Hep C, but what's happened in hepatitis C space, that no longer is a diagnosis that is going to require a lifetime of dialysis or possible kidney transplant because we're able to cure those diseases with that technology. Does it cost money? Yes. Everybody up here has some sort of cost of healthcare, right? But it's offsetting other costs of hospitalization and other treatments when folks do get the medications that they need. And I'm sure Milam would agree with me, and he talked about it a little bit, that adherence is sort of the thing that we'd all like to see improve. And the good news is there's more to come. That right now because of advances in technology, there's 7,000 medicines that are in development for cancer, for immunological disorders, infectious disease, the Zika virus. I mean, that's the folks that are going to tackle those diseases that we hope never hits any of us or any of our loved ones, but as the human condition, disease comes to us. So I think, we kind of sit here, public policy, we tend to try to get in camps and say, we're one group versus the other. But I think with our industry, what we look at is our enemy is disease. And, the folks that are researching and developing new medications are doing that for anywhere from 10 to 20 years. They may work on one product in that lab. And so we want to make sure that we get to affordability, but we also want to make sure that this American ingenuity continues and we continue to tackle these things. Just one stat, if you look at Alzheimer's, which is, it's affected my family. I'm sure it's affected a number of you in this room. Alzheimer's in the next 10 years will be about $250 billion problem in this country as the population ages. And that's one that we haven't tackled yet. I mean, we have some treatments, but it's another one that's got to, we've got to go to the labs and keep on doing this research and being able to fund the research. So I'll stop there and we'll go with it.
Most of you probably read some of the headlines involving Martin Shkreli. Remember that? He invoked the Fifth Amendment during his grilling by Congress, and probably if I had represented him, he probably would not even have appeared. He would have just remained in jail to protect himself. But in any event, he was the former CEO of Turing Pharmaceuticals who faced federal security fraud charges. And at the hearing about drug prices, Turing and another company, Valiant Pharmaceuticals International, which had both acquired the rights to not so much these new fangled specialty drugs with a lot of R&D, but more particularly some old drugs. For example, Turing acquired the rights to Daraprim, which is a 62-year-old drug for parasitic infection, and raised the price to $750 a pill. And then Valiant increased the price on numerous old drugs. These were heart drugs called Isopril and Nitropress. When they acquired these drugs, because the patents were already out, it increased the price by more than 500%. Can you tell me what pharma's position is and why these kinds of drastic cases are making a really, really bad name for pharmaceuticals and blaming the cost of rising health care on pharma?
Sure. I think you can imagine that in the halls of our home office, we do not have a picture of Martin Shkreli up. That is not who we represent as the research-based manufacturers. And certainly, as Milam said, that a large number of products are off patent, and so they are marketed as generics, and that's not who I represent. I think we've had a number of our CEOs try to distance themselves from Mr. Scarelli and the practices, not only of his company, but also of the practices that Valiant has undertaken. Kind of talking about patents for a second, just so folks understand, that's obviously the core of our business is research. And what we do, I think most people think the patent starts when you start selling a medication, and that's not the case. Patents run for 20 years, and that is when you discover whatever you're going to develop, that molecule, that new biologic that's filed with the patent office, and then research starts. And research typically takes 10 to 12 years, and so before you get FDA approval for a medication. And so you have that balance of that patent life to actually market the medication. So I think that's important to know. In the case of Mr. Scarelli, who, by the way, as you mentioned, has some issues with the federal authorities, but he also, what happened in that case was another generic manufacturer came in and sold that drug for $1 a day. And so in that instance, the marketplace corrected itself because those were certainly some extreme pricing models. But I think it's important to understand how the life of a patent, because it's key to understanding as we move from brands to generics, and then in the new space of these more complicated technologies and biologic drugs, which you talked about Humira, that's a biologic medication. I should take that medication for psoriatic arthritis, and it's a miracle drug. Literally changed my body chemistry, and at some point there will be a biosimilar, which is sort of like a generic, but not exactly. And there was legislation in Louisiana last year that will regulate how you're able to switch those products at the pharmacy counter as they become available. There's only, I think, one that's been approved by the FDA last year, but that will start to alter some of the pricing, just as generics did over the last 20 years.
Our healthcare delivery system needs to be redesigned. And what is prompting that is, number one, the need for redesign, the need to improve health outcomes among a population, but it's also the payment model that is changing. And as the payment model changes, the delivery system will change as well, so that the principal ways that health systems and hospitals actually generate revenue in today's world will change as we move into this value-based world. So what we're talking about is the transformation from a volume-driven, transaction-based system, where care all too often is fragmented, to a value-driven, outcomes-based system where care is highly coordinated. Yeah, so the United States is spending more on healthcare than any other country in the world by a long shot, like 2.5 to 3 times as much as most countries. And yet the Commonwealth Fund would actually rank us dead last, 11 out of 11 among the 11 richest countries in the world in terms of how we are generating health. But what we also find is that there are pockets of innovation within the country where there are health systems that are delivering health and health outcomes at a very high level, and generally doing it in a less expensive manner than others. And so there are companies, national companies, that will actually fly patients to those health centers in order to get better health and health outcomes. And so certainly I think what we want for our community and for the people of Louisiana is for health systems here to try to compete on that same basis of who can deliver the best products, the best services, the best care outcomes, and do it at the lowest cost.
Long-term care and the crisis in that marketplace truly is a threat to the very, very important state-based regulatory system that has proven itself through the Great Depression, through the Great Recession, and for over 100 years of state regulation of insurance to be, number one, in the interest of policyholders, and number two, to be in the interest of the market as well. That system has truly been successful in protecting consumers and in providing a competitive, viable market for all products insurance. But the one that is looming as a threat to that system more than any other is long-term care. And I can summarize it for you with what Genworth, the former GE long-term care plan, has told us publicly in all 50 states, twice here in Baton Rouge. And that is that they have 40% of the national long-term care market share, and they need a 60% rate increase on that book nationally. I get gasp, I get, oh my goodness, reactions whenever I share that with folks who were not previously aware of it. And they are not unique in that position. Long-term care insurance was rolled out 40 years ago on two bad mistakes. One is life expectancy, and the other is cost of care. Today, it costs $81,000 a year to keep a patient in a nursing home for 1 year. In 2030, it will cost $146,000 a year. That's 14 years from now. That rate of inflation for long-term care costs is going up at 4.5% per year, twice the rate of inflation overall for our economy. If that system collapses, if it fails, then typically politicians don't do reform with scalpels. They do it with hatchets. And they will take a hatchet to the state-based system of regulating insurance. And the damage, the collateral unintended damage caused in such, quote, reform, close quote, truly will represent a serious threat to the system that has served us so well for the past 140 years. In closing, one last thing I would like to add in that regard. As we speak, my 95, well, he'll be 95 next month, my 95-year-old father-in-law went home from the hospital yesterday with his daughter picking him up and taking him home to continue living in his home with around-the-clock caregivers. My 93-year-old, next month 94-year-old mother lives with my sister down in South Florida, still has a home in Jefferson Parish, and will be back visiting there, I'm told, sometime this summer. Both of them represent what I tell folks all over wherever I go, the blessing and the burden of our generation. It is so typical of what all of my contemporaries are experiencing in giving care and attention and love to those that we are blessed to have for almost 100 years in so many instances. That is the cause of the crisis in the long-term care arena. We are living longer, and now they're telling me we're going to have a monitor in our wrist and take our medicine by computer. A couple other things I wonder if they'll do for us by computer as well, but I won't go into those in this audience. It's scary what is being planned for us and probably in reach for us going forward. But these are some of the issues that we'll be talking about here today from all of the perspectives that I mentioned before. And it is so important to get your feedback, your expertise in going forward with these things. As I say so often in the regulation of insurance, there are no silver bullets. If they were, they'd have been put into play a long time ago. All of the reforms that we make, whether it's in property insurance, auto insurance, long-term care, or health, are done one Band-Aid at a time. And just today, here in this room, we might come up with a couple of Band-Aids that not only will help us, but will spread across America and make the entire system better.
We've got a new governor and new executive leadership who, with our legislature, of whom many are new and challenged by this amazing budget crisis that we're facing, we recognize in this room the only two places that you can do anything about a constitutionally required balanced budget is healthcare and higher education. And hence we will see that even though one of the first executive orders, the first executive order that this governor signed into law affects every person in this room and beyond, which is expansion of Medicaid as one of the states that originally did not want to expand Medicaid after the Supreme Court decision that allowed states to opt out under the Affordable Care Act. Louisiana finally made a decision to go forward, and June 1st, the enrollees are attempted to begin their process to enter into the system, which of course will mean, in terms of healthcare access, quality, and cost, a brand new world that we will be living in Louisiana. And while other states may have already experienced what the impact is of having the uninsured or previously uninsured now covered under Medicaid, what will that mean in terms of rates and access? Those are the two areas that I think you'll hear much more about in today's program. Also, I think we're going to hear about Louisiana and how challenged we may be if the public-private partnerships that were responsible for taking over the public hospital systems in Louisiana face the additional challenges of cuts. What happens when you're looking at not this year, which is a $750 billion deficit, but next year a $2 billion deficit? What happens in terms of the services that the state is required to provide? And finally, I think it's important for us to look at the federal level. Look at what CMS estimates in terms of how we are growing the federal programs, Medicare and Medicaid. We predict from 2006 to 2022 that federal level access to insurance, Medicare and Medicaid, will increase from 57% to 71%, whereas private insurance will only grow 6%, with very few covered in the United States by private or employee or the kind of employee-sponsored benefits that we think of today. That's going to change. And we believe with high deductible plans that are going to increase significantly and healthcare being placed more in the hands of individual consumers, the marketplace has got to change. We see it not just in the insurance sector, but also we'll see it in the provider sector, where the providers have been forced to become much more creative, where we see ACOs now that may be competing with other types of healthcare plans, where the physicians say, fine, I get it, I'll take this population, I'll insure it myself if I'm going to be responsible for the outcomes in any event. This is a very serious time in Louisiana's history. We've got one of the worst budget crises we've had as long as I can certainly remember. And staring down the barrel of a rising cost in health care, access issues that will hopefully become better as a result of expansion of Medicaid, which should take place in June. We're going to see some major changes, but dependence on government financing is going to become much more difficult. The only place, as you know, that there can be cost-cutting measures in the state is higher ed and health care. Those are the only two discretionary places. So I think we're going to see these two areas come to sort of a cliff by design. What happens when we can't take any more money out of health care in order to balance our budget, and at the same time we're going to increase access, which is a good thing, through Medicaid expansion?
What expansion really is, though, this expansion, is an opportunity to repair a system that's gotten more and more broken over the years. And I'll discuss some of the breakpoints that have happened. But before we get into that, we kind of need to talk about where we are, and that reality has three components: our health stats, our financial status, and our system structure. So this is where we are. This is the ugly truth. We're sick. We're last in overall health. We're incredibly unhealthy. Everybody always talks about how we drink too much or we eat too much, and you can see it here. We do more than that, though. We're also near the top in smoking rate, and we have an extremely low educational attainment. We use dangerous drugs at a high rate. We're also last in healthy community and environment. That's being driven by those bottom ones, high crime and high childhood poverty. It's not all bad news. We're fourth in health disparities and third in Tdap immunization, but unfortunately what that essentially means is we're all sick. Nobody's healthy. The good news is it's not whooping cough, so we've cured that. And just when you thought the good news was over, I want to talk about the DHH budget. I'll give you kind of the cheerier version. For the next fiscal year, DHH expects a cut of roughly 10% across the program. In Medicaid, that cut by itself will likely close several hospitals. It'll drop the Value Health MCOs to the lowest actuarially sound payment possible, which is actually the lowest I can pay them under federal law. And you can imagine what that's going to do to providers. It gets even worse if you look at the 20% reduction, which is what's been suggested if the legislature doesn't take action to raise revenue. That closes pretty much all the public-private partner hospitals, essentially putting charity care out of business. Hospitals that remain, the private hospitals, will essentially have to take that into their emergency room without payment. It eliminates GME. It eliminates several critical behavioral health programs. It significantly underfunds the rural hospitals. It ends Medicaid waiver services for children with developmental disabilities and for aging adults. There's not a lot of downstream relief in sight. The department's bumping up against its Medicaid upper payment limit for hospitals to the degree that private hospitals called LINCA partners have begun to get squeezed out of the program. Essentially, we have a cap in our supplemental reimbursements, and we're at that cap now, so as we need more and more supplemental reimbursement as medical inflation happens, hospitals actually get bumped off that list and get $0. Disproportionate share hospital payments, which is the other supplemental part of the program, is scheduled for significant reductions as part of ACA. It was originally scheduled to step down, I think, starting in 2014. That's been bumped back. We're now expecting 2018. The general health status of Louisiana, I think it's no secret that we're 50th in the country in pretty much any ranking by any measure. And what we're doing to try to address that, mainly Medicaid expansion, but then the build-ons after we've expanded, things like value-based payment, health data, just sort of the general thrust to get out of that 50th spot and move up the rankings.
What will it take for Louisiana to move higher in the healthcare rankings?
Well, one of the big things that we're going to need to do is change behavior. If you look at the determinants of health, we are last in the country in pretty much every one. We eat too much, we don't exercise enough, we drink too much, and we have high drug use. So if the inputs aren't there, then the outputs aren't going to be great either. But it's also about reforming the system and incentivizing people to actually use care correctly.
What are navigators? Navigators, and who are the assisters around the state? Navigators play a vital role in helping consumers prepare electronic applications to establish their eligibility and enroll in coverage through the marketplace. In Louisiana, navigators are certified by the federal government. We are licensed by the Louisiana Department of Insurance and have undergone rigorous training, criminal background checks, and fingerprinting prior to assisting consumers. In addition to navigators, the Federal Facilitated Marketplace has designated organizations to certify application counselors who perform many of the same functions of navigators, completely free at no cost to the consumer, including educating consumers and helping them complete their application for coverage. These groups include Louisiana's federally qualified health centers, as well as other community health centers, healthcare providers, hospitals, and social service organizations. And then also there are licensed agents and brokers who assist consumers in applying for qualified health plans, which we call QHPs, and the insurance affordability programs, including premium tax credits and cost-saving reductions. They play a crucial role, or you play a crucial role, in educating consumers about the health insurance marketplace, both during the annual open enrollment and throughout the coverage year. Next slide. So here's a map of Louisiana. It shows that in Louisiana we have two entities who serve as navigators. My program covers the entire state, and there's also a capital area, Family Road of Greater Baton Rouge, which serves as the navigator entity for the capital area. Next slide. Across the state, we have 9 offices located in the Shreveport area, Monroe, Natchitoches, Alexandria, Lake Charles, Lafayette, Hammond, Baton Rouge, Monroe, and New Orleans. Next slide. Louisiana is allocated through a formula determined by CMS for about $1.5 million for navigator services. So it's not a lot of money. We've got, like I said, we've got 9 offices across the state. We spend a lot of time in rural communities, so we've got a lot of funding for travel. It gives us the ability to have about 19 navigators across the state. So we've divided them up by regions. There's a regional map there showing where we work to make sure that all consumers around the state have access to navigators. But in addition to the navigators, there are also the 34 different federally qualified health centers across the state with 189 facilities, and combined they have a total of 180 certified application counselors. The federal qualified health centers are organized by Louisiana Primary Care Association, who supports their outreach and efforts throughout statewide community health centers. And last, but most importantly, not least, the Louisiana agents and brokers in the marketplace. In Louisiana, insurance agents and brokers have played a key role in the health insurance marketplace. They have educated consumers about marketplace and insurance affordability programs. They've helped consumers receive eligibility determinations, apply for premium tax credits and cost-saving reductions, compare plans, and enroll in coverage. In addition, agents and brokers play a critical role in helping qualified employers and employees enroll in coverage through the Small Business Health Options, or SHOP. In Louisiana, consumers may want to obtain professional advice, and so agents and brokers, when they apply for selecting qualified health plans. So let's look at where we've come in the last 3 years through open enrollment. So in year 1, which was 2014, we enrolled a total of 101,778 individuals. In year 2, we increased that by 183% to enroll 186,277 individuals. And then in 2016, which we are now, at the end of open enrollment, which was the end of January, we had enrolled a total of 214,148 consumers. That 214,000 is a 213% increase that we since the first year. So what you've seen is a number of individuals who are buying into the qualified health plans, and you see that the rate of interest in this throughout Louisiana has grown as we go into our 3rd year of open enrollment. So who are these people that are coming into the marketplace, and what do they look like, and where are they coming from, and what is their financial status? Let me tell you a little bit about that. So in 2016, as we said, we've got 214,148 people who have gone to the marketplace and have chosen their plan. Out of that, 103,065 are brand new consumers that are coming to the marketplace for the very first time. An additional 111,083 were re-enrollees who enrolled from the previous years, or from the previous year. Okay, of that 111,083 re-enrollees, what did they look like? Well, 71,490 are active enrollees. That means they went in there, they looked at their plans, they chose a plan that more suited them than they did the previous, versus the 67,877 who automatically enrolled, meaning last year when they enrolled, what they did is they just chose the auto button to automatically re-enroll them in the same plan or a similar plan. Next. So what we ended up with was 243,919 total applicants who completed their, total number of people who completed their application for 243. Obviously not all people went through to the plan selection, but that's where we were. Of that, 285,618 total individuals completed their applications. You've got 270,608 people. That's your total eligible to enroll in the Louisiana marketplace. They went in, they went to healthcare.gov, through help, they were able to be determined eligible. Of that, 211,291 enrolled in a marketplace plan with financial assistance. The number of individuals, 12,862 were determined eligible for LaChip and were referred over to the Department of Health and Hospitals for enrollment in LaChip, which is the Children's Insurance Program. And 214,148 chose the plan. They went all the way through the process to choose a plan that most suited them. Next slide. Let's see. Okay. So of that, a number of individuals with financial assistance, 211,291 individuals were deemed eligible for some type of financial assistance to help pay those premiums, and 59,317 were deemed not eligible for that. Either they were below 100% of the federal poverty rate or above 400% of the federal poverty rate, okay? So when we look at that, of the 148 people that chose a plan, a total of 190,591 chose plans with assistance, some type of financial assistance. And just about 100% of those chose that assistance to be through advanced premium tax credits, meaning that they received that assistance each month versus at the end of the year. Okay, and then of that, 130,631 fell between 0 and 250% of the federal poverty level. So this meant that they qualified for some type of cost savings reduction as part of their plan, helping them with their premiums, helping them with their co-pays, out-of-pocket expenses. So what does the age look like of those that were enrolling? Well, we have about a little over 10,000 that were 18 years or under. Let's see, a little over 25,000 are between the ages of 18 and 25. Almost 43,000 are between the ages of 26 and 34. 36,000 are between the ages of 35 and 44. Almost 45,000 between the age of 45 and 54. 51,000, which is their largest group enrolled, is between the ages of 55 and 64 years old. So the number one group is the 55 through 64 age range, then the 45 through 54 age range, and then the 26 through 34% age range. And I think what's important to note on this is that if you look at the ages of between 18 and 44 years old, those are the number of people who enrolled under 44. And that is significant because we generally think of those as your more healthy age group. And so that's very important. Our big focus has always been to push the young invincibles and to enroll them. They're probably some of the hardest groups to reach. In making them understand that the importance of having health insurance when they're trying to struggle and they're trying to start a family and a house and all of the things that come with that age group. So let's look at it by gender, all right? So of those 148 people who selected their plan, 43% were female and 50% were male. What type of plans did they choose? Well, we've got almost 45,000 chose a bronze level plan. The number one is the 152,044 who chose the silver level plan. And I think that's important because those are where you're going to get those costs. When you choose the silver level plan, that's where you get those cost savings reductions as part of that plan. 12,849 chose a gold plan. 2,141 people chose there are very few platinum plans that were available in the marketplace this year, and the 2,141 chose a catastrophic plan. Catastrophic plans are those basic plans for the very young, between 26 and 30 years old. So let's look at the race and ethnicity of those that have enrolled with this. Well, if we look at, I think it's important to note that race was self-reported, so we don't have this is only of those where we had reported race in there. So the number one group that was to enroll was the white Caucasian community with 124,205. Second, we go to the African American community with 47,820, or 27% of those that enrolled. The third group is our Asian group with 8% at 17,132. Fourth group was Latino group with at 5% with 10,770, and then we have a multiracial group of 1%, which was about 2,100. Then when we look at the zip codes, okay, of those that enrolled, what we see is that 177,742 people come from a zip code designated as urban, whereas the 17%, or 36,405, come from rural zip codes. So let's look at the marketplace. Let's look at the household income, okay? So what we see here is we see that 97,611 falls somewhere between 100 and 150% of the federal poverty level. Then you've got 42,705 that falls somewhere between 100% and 150 and 200% of the federal poverty level. And then 22,369 falls somewhere between 200 and 250%. So together, all three of those are the ones that qualify for those cost savings reductions because they're between 100 and 250% of the federal poverty level. As we move on, 16,269 are between 250 and 300% of the poverty level, 14,000 are between 300 and 400%, and then 4,067 people are over 400% of the federal poverty level. So when we break it down and we look at it by public health regions, you can kind of see that. You can look at the map, and I'll give you a quick second to look at that instead of reading all of these to you. Obviously, this pretty much follows where we find population data around the state. I mean, New Orleans has got the heaviest number of people who enroll, but it also has the most people in that population.
I think what you saw is in the first year we had about 110,000 people enroll. The second year we had around 189,000 people enroll. And the third year we had 214,000. So what we've seen over the last 3 open enrollments is this growth. Which that means is that this is something that people in Louisiana want. You know, and as we go into an expanded Medicaid, we're going to have something for everybody. So a lot of the people that wanted to enroll fell into that gap of less than 100% of the federal poverty level. So this expanded Medicaid is going to be able to fill that gap. So eventually, hopefully next year, everybody will have access to some form of health insurance.
The main message here today is that there's a lot of changes going on in the ACA, and especially in the agent and broker community. One being that they're losing their commissions. And what that means to the American people, to the citizens of Louisiana, is that the consumer loses their choice. They lose the option of choosing an expert or not. So when the insurance agent is not paid, and of course they can't work for free, the consumer loses the option of having someone help them through this difficult road of choosing a health plan that works for them.
What role do independent insurance agents play in helping people navigate through the Affordable Care Act?
And that's an important question because a lot of people think insurance agents work for insurance companies, and we do not. We work for the consumer. So what we would do is sit down with the consumer, figure out the best plan that works for them. Are their doctors covered? Are their hospital covered? And is their medicine covered? So sometimes it's very complicated for those that are sick and ill.
My message today is that for Louisiana, for the insurance market in particular, individual to work, we all got to be in it together. It's got to be the regulators, the Department of Insurance, all the agent community, and the carriers, and we have to put some pressure on the federal government to enforce the rules that are in place to make it a long-term sustainable market for the individual marketplace.
What would you like to see the federal government do in this area?
Well, the biggest thing, again, is kind of enforce rules that they've already passed. So there are rules on the books that are part of the law, and they're not being enforced, and it's having consequences for everybody, from driving up rates, lowering commissions. There's a lot of bad that's coming from that, and really just enforcing the rules on the books could make a big difference.
From a carrier standpoint, all of the health plans are coming here to talk about the Affordable Care Act and the effects it's having on our business and what agents and what the public can expect in the upcoming year with the Affordable Care Act and the insurance that all the health plans provide.
What have you seen over the last several years now that the Affordable Care Act has gone into effect?
Well, the Affordable Care Act is, for our company, Vantage Health Plan personally, it's allowed us to expand throughout the state to all markets. So we got immediate exposure in the southern part when we were formerly known as a North Louisiana plan. So that's been a good aspect of it. However, picking up this new membership for all the health plans. The utilization has been high the first few years, so we're hoping that that will calm down as people now are seeking health care who have not sought health care in the past. So as we get some of those illnesses taken care of, we hope to see utilization hopefully to come down in the next few years.
We have a very large group of members on the exchange in several states across the country, and we continue to work on that business. We continue to want to grow that business and focus on that business, but we also have many other areas of our company where we're focusing on as well.
Tell us, what changes would you like to see in the Affordable Care Act?
I think one of the specific changes we've been talking about are changes around the special enrollment periods, and we have been looking to CMS to make some improvements to the special enrollment period process, validation of members' ability to enroll in those special periods. So I think that's probably the most important thing that we've been working on right now.
As many of our institutions across the state move towards an electronic health record, and the sunset time that we have for making that happen, significantly driving up costs. Yes, they're a one-time investment, but it is a huge investment that we all have to plan for and implement in a very short time frame. So it's significant budget implications.
There's so many bills that are taking place. First of all, the budget is a key driving force on what we as health plans and the industry are looking at. But also we need to look at ourselves and what are the driving forces of the high cost of healthcare. And so we have the increase of pharmaceutical costs that are going through the roof currently, and we also have inpatient, outpatient care at the providers such as the hospitals and for doctors. And so there are several bills dealing with consumer right to know on consumer pricing, but also transparency of pricing and how we can give the consumer as much information as we can.
Tell us, what do you see as the advantages and maybe some of the disadvantages of the Medicaid expansion, which begins July 1st?
Well, I think one big advantage is that we're going to see people coming into the system for the first time, not having to depend just on emergency room access for their primary and other urgent health care needs. They will be able to have access to see physicians that take Medicaid and to be part of a system of health care, which I think will help them in the long run and help us. The other advantage I see is that concerns about rising cost of premiums are greatly driven as a result of having to balance, as it were, on those that have insurance, the cost of those that do not have health care insurance. So that's another advantage that I see. The disadvantage, of course, is that there'll be some growing pains. We won't know how to fit all of those folks into the system. There's a shortage of physicians now, and the question is whether or not we will be able to have enough physicians and be able to pay them at the adequate rates necessary to be able to have this expansion and have people have access to their physicians.
Are you encouraged by everything that you've seen and heard here today at the healthcare conference?
Yeah, I'm greatly encouraged. I think we have a very open mind to change. I think we're going to see more change in the next 3 years. I think we're going to see innovations in healthcare at every sector. We're going to see providers innovating more, acting more like managed care companies. We're going to see managed care companies acting more like providers and trying to really get to the crux of what are the costs that drive healthcare. We're also going to talk a lot about pharmaceutical cost and whether or not that big driver that we hear so very much about on the press and in congressional hearings, whether or not there will be some ways of tapping down those extraordinary costs, making the price of pharmaceuticals outside of the ordinary reach of anyone.
I am encouraged. This is a great conference. The insurance commissioner and his staff do an excellent job of putting on a great show, an informative show. We can also get continuing education hours, so it's good from that aspect as well.
It's exciting to see so many independent agents and other providers that are here just trying to learn and become more educated. I've seen some type of provider groups that are not independent agents or insurance companies, so it's nice to see everybody in one room.
It's an awesome time to bring together providers, brokers, people in the health insurance industry. We're often put at odds odds with one another as competitors when it comes to healthcare. And so when we come together around the table of collaboration to understand the perspectives from each of our industries, I think it builds a better, broader understanding of how we collectively can solve some of these questions and challenges to make our state healthier.
Very positive, and there's a lot of information here that I'd be happy to share with your viewers. We can be reached at 1-800-259-5300, or if it's a simple question, through our website at www.ldi.la.gov. That 800 number again, 259-5300.